Hello, I am Dr. Rahi Victory, and I am your host of Fertility Factor Fiction, where we bring you the latest and greatest in all things fertility and try and make your journey more successful, a little more exciting, and a lot less hassle. So we are with you live tonight with my trusty friend Tarek, who's currently trying to get the camera to work properly. And we don't have a topic because there weren't really any exciting articles that came out that I wanted to share with you. So we decided we'd do another one of those nights where we go right into questions. Sorry for the day change. I am on my way to the Midwest Reproductive Symposium conference so I can learn more about fertility for you guys and bring it back to implement things that we need to change in our practice. So we're going to go right into questions. Many of you already wrote to us tonight, and so we have things that we can go over. Oh, and we had Chinese food for dinner. So my fortune cookie said, something special will happen at home soon, except I'm alone at home. So I hope something not so special happens because that's going to be very awkward. All right, fire away.
You read that? I didn't think that would be a public comment, but it's for the fun. So I removed my tubes after our second child.
Okay.
Can I still have another baby with IVF?
Yes. So if you've removed your tubes, IVF is ideal for you because we bypass your fallopian tubes. So basically, we are taking eggs out of your ovary, bringing them outside your body, making them into an embryo, and then taking the embryo and going through your cervix and going back in. So your tubes are never used. And in fact, not having them is actually kind of an advantage when you're doing IVF. So yeah, you're like the perfect candidate for it. If you don't have tubes, IVF is absolutely right for you.
Should flora be taken during or after a course of antibiotics for FET prep? You are amazing. Oh,
thank you. I didn't know they weren't talking to you.
No tea.
No tea. Oh, ouch. Thank you. So yeah, flora should be taken during and after, because what's happening is you're killing the bad bacteria and you want to oversaturate the uterus with the good bacteria so that the bad bacteria can't come back as soon as the antibiotics are done. So the whole idea is think of it as like a room, and you can fit like whatever, 100 people in this room, like, you know, crammed in together. So what you want to do, well, let's not use people because this will sound terrible. So you've got 100 balloons and you can shove them in this room, and you've got a bunch of polka dot balloons that you don't want because those are not good balloons. And then you've got all the other colored balloons. So what you want to do is kill off the polka dot balloons, but you need to shove in the other colored balloons in there so that there's no space for the polka dot balloons. So that's the way that you want to treat the bacteria. So you want to take the flora so that the good bacteria jump in there and take up all the space so the bad bacteria cannot get back in there and grow.
Which is better, neupogen or HCG
wash? So we were just making a video about this yesterday. So HCG wash has about a 30% increase in your success, and neupogen is also between 20 to 30%. So it kind of depends on what you want to do. There's no harm in doing both. It's just cost.
How many US are safe in a pregnancy?
Ultrasounds.
Ultrasounds. My clinic says they don't want to do too many.
So you're not allowed to do too many in Ontario. We're allowed one for dating, one for the nuchal translucency, one for anatomy, and more only if there's a problem. But there actually aren't any safety concerns with doing ultrasounds because we have many people that get ultrasounded daily for weeks on end throughout the pregnancy, and there's no compromise with their babies. So my own oldest child was part of the development of 3D ultrasound technology. We used it when we were pregnant with him, and they used my wife's ultrasound images to help develop the 3D technology. And that kid is one of the smartest people anywhere. So it definitely has no negative impacts on anything. And congratulations, Matt, who graduates this coming Monday. Amazing job, kid. We're very proud of you. We love you.
How to help insulin resistance for FET beyond low carb diet, normal BMI, minoxidil.
Inositol, NAC, NAC, coenzyme Q10, resveratrol. All 4 of those are good supplements to use. You want foods with low glycemic index for sure. Regular exercise will help. There are some cases where if you actually have the insulin resistance, taking metformin makes sense even if you're not obese. So if your BMI is regular, but you still have insulin resistance, metformin will help you and should be considered. So those would be the natural and the medical and then the health kind of lifestyle things that you can try. So NAC, inositol, resveratrol, and coenzyme Q10, all 4 shown to be beneficial for patients with PCO. Metformin, if you want a medication, and then healthy diet and exercise, those will all make a big difference.
Hello, Dr. VNT.
VNT, you're back in.
And this is on a pre-question.
Oh,
You know?
That's got more cachet.
Yeah. This is serious.
All right.
And listen to the question they're asking me.
All right.
Could you please share your FET protocol? Just do whatever Dr. Victory says.
Just do it.
That's my take on it.
Okay. So our FET protocol is pretty simple. Well, actually, no, it's not simple. I take that back. Okay. So cycle day 21 of the preceding cycle, take a shot of lupron. Cycle day 3 to 7, take letrozole and take antibiotics. We usually use a 5-day course of Zithromax. On cycle day 7, when you're finished your antibiotics, start a 10-day pack of a probiotic that you like. Stay on aspirin and melatonin the whole time. Throughout this, you need to start getting monitored, usually a baseline scan and then maybe one on day 10. See if your lining is getting thick enough. If your lining is not getting thick enough, start the most minimal amount of estrogen possible. We use like 1 milligram of estrase. Wait till your lining gets to about 9 to 10 millimeters, 8 to 10 millimeters. When it gets to 8 to 10 millimeters, start vaginal and injectable progesterone. Wait 3 days, check your progesterone level. Make sure it's between 40 and 100 nanomoles per liter, and then wait the requisite number of days for your embryo transfer, 5 days of progesterone for a day 5 transfer, 6 days of progesterone for a day 6 embryo transfer. Other stuff that we use steroids right before. We make sure that the patients are on whatever vitamins and supplements that they need, iron, vitamin D, the fish oils, a good prenatal. That's pretty much everything we do. We use Matrix, but I'm not sure that it works yet. And we use compression to make sure that the lining actually shrinks a bit after you start the progesterone so that you know it's responding properly to the uterus and actually working to help compact that lining.
Have you ever seen Nips by Invita reporting wrong gender at 11 weeks?
Yes, I have. But it was in a case where there was twins and one of them had passed away. So they got the wrong one, but that's possible by virtue of what had happened.
Any advice to help husband feel comfortable giving a sample for semen analysis?
How to make husband feel comfortable? Oh boy. Number 1, go with them. Most places will allow you to go in as a couple. Number 2, avoid going in. Just like do it at home and take the sample in. That's fine in a lot of places also. Number 3, tell him that he's your hero for doing it. Make him feel good about what he's doing and his contribution. Number 4, tell him that it's okay to be afraid or embarrassed or concerned, but that there are loads of other guys that are doing it as well. Those are all the strategies we use. But most of the time we just tell the women to go in with their guy. Then you can make it fun. So there's no harm in doing that. And if he's really uncomfortable, just do it at home. We don't force our patients to come in. You can do it at home and bring the sample in. And as long as you verify that it's yours, that's fine.
My AMH was 0.8, age 25. Now it's 1.8, 5 years assuming later. And 1 IVF baby later. Why?
That's a damn good question. So AMH can vary, and depending on your vitamin D level, whether or not you want birth control when they tested you, what your weight was, your stress levels, those sorts of things, it can vary. I don't know if you're using nanograms per mil or picomoles per liter. If you're talking about picomoles per liter, 0.8 and 1.8 really aren't that different. If you're talking about nanograms per liter, that's actually quite a substantial difference. I would say they probably made a mistake with one of the two values, and I'd probably get it rechecked to see where you're at. But it can be up and down. I mean, I had a friend of mine who shall very much remain nameless, who had horrible ovarian suppression because she had been on the birth control pill for many, many years. And then we were really worried about how many eggs we would get from her. So we didn't do anything quite that quickly. We waited until she went off the pill for a couple of months, brought her back, and then she had gangbuster ovaries. They were amazing. So it depends on what's going on with you, how close to a suppressive event or medication you were getting measured. So that would be the most likely source, I would say.
So a question that's not in order, but because it's good.
Okay, you're going to ask it now.
I'm going to ask it now.
All right, fire away.
I'm cutting.
You're cutting. You're
Yeah.
cutting in line? All right.
Yeah.
All right.
Hi, Dr. V&T. Regarding the velvet couch question last week,
Okay.
I think it should be green, symbolic for life. How early can you test at home after an FET? She threw her actual question.
She threw the question in there. Yeah.
It deserves.
You know, if we get a green couch, it's going to look like I'm sitting on nothing because it'll be like green screen. It doesn't show up on the camera. That'd be funny.
We can do a lot with that.
We could probably do a lot with that. Yeah. Okay. So the earliest home tests, if you're really lucky and you get one of those expensive tests, which by the way, only have a 63% chance of detecting a pregnancy, you're going to detect it probably around like 9 to 10 days, maybe 8 if you're really, really pushing it. So we don't encourage people to do that because in many cases, you don't know if it's residual HCG from an HCG wash or from a trigger. You know, there's a lot of different reasons. You don't know if it's going to continue going up and everybody starts panicking. So I know the 2-week wait is terrible. And I apologize for the fact that the 2-week wait is terrible, but it's really important you just wait. So wait.
I got a 2-part question here.
A 2-parter. All right, part 1.
Part 1. Day 4 recovering from lap septum removal. And one
lap septum removal? I guess a lap and a septum removal. Okay, yeah.
And one spot of endo. Balloon in place for 2 weeks. I'm 35 with 1 embryo. Curious what would be next steps.
Well, if you had 1 spot of endo, there's probably more. So we would use an endo protocol. So 3 months of lupon and letrozole, and then a letrozole cycle with very, very little estrogen, NAC, coenzyme Q10, resveratrol, and curcumin for supplements. So those would be the basics. I would double check your lining with 3D ultrasound before I would agree to doing the transfer. I think those would be the main things we would do for you.
Do you believe in DQ alpha matches? Is diagnosis of infertility or keep digging?
Okay, so first of all, DQ alpha is not supposed to be a problem for fertility. It's supposed to be a problem for staying pregnant, not getting pregnant. I don't know. Do I address it? Yes. Am I sure that it's a problem? No. It's probably one of the most controversial things in all of fertility. So there's only 2 really good studies on it. And then there's a 3rd one that I found after a lot of digging. So study number 1 said, if you are a full DQ alpha match, you are absolutely never going to get pregnant together. It's impossible. It'll never happen. The results are a disaster. It's horrible. I was like, oh my God, this is really bad. Number 2 study said, even if you're a complete DQ alpha match, it makes absolutely no difference. You're no different than anybody else. You have the same chances as everyone else does. And then the 3rd study I looked at said it wasn't DQ alpha, it was DQ bravo or beta, and that was the bad one. So like, I don't know. We get the report from Fertility. When I find it, I review it with my patients. I talk to them about their options. you're supposed to consider things like either LIT or subcutaneous IG. Whether or not it works, I don't know, but we have very few people we can't get and keep pregnant. So, I mean, I think it works.
Is Menopause okay for PCOS patients? Is follicism or gono better?
The mixture is best using Gonal-F with Menopause, but Menopause is particularly good for patients with PCOS. So I would use it. Yeah.
Is Zotolex injections good for adenosurpression?
Zoladex injections are excellent for adenomyosis suppression. Yeah. So it's a GnRH agonist, which means it floods your brain with the signal that your brain normally sends in a pulsatile fashion to your pituitary gland to tell it to make FSH and LH. So by sending it all at once, it shuts down the pulsatility. That shuts down FSH and LH production, which in turn shuts down estrogen and progesterone. And because you shut all of those down, the adeno goes quiet because adeno feeds on estrogen. So yes, it is excellent suppression.
What are the absolute best supplements for PCOS?
The four I mentioned earlier. So NAC, inositol, coenzyme Q10, and resveratrol. Those are the ones we use here.
Does cysts cause poor IVF outcomes for low AMH patients?
Does what?
Cysts
Cause
poor IVF outcomes for low AMH patients.
If you have a cyst, you should not be going through IVF usually. Now, in some instances, it's okay, and it depends on the type of cyst. But in many instances, the cyst will interfere either physically by getting in the way of the needle. You know what? That's a good sharing opportunity. Let's share. Or it'll get in the way of, I got to connect to you. Or it'll get in the way of the egg development hormonally. So that can be a problem because if it gets in the way, we can't do what we need to do to stimulate your ovary to produce even one egg, and then you got major problems. So if I draw this out for you in black. Okay, so when we are doing IVF, we have your ovary kind of sitting, oh, that didn't work. So we have your ovary sitting over here. I think I was pushing too hard. And then if you have a cyst, which is here, and then your follicles are back here, we can't get a needle to go through because there's no way to get it past that cyst. So that's a huge problem because you want to make sure that actually looks like a really angry lollipop.
Lollipop, magnifying glass.
It's a really angry lollipop.
Whoever's tuning in right now has no idea what you're talking about.
So you can't get to those follicles at the back because the needle has to go through the cyst. And depending on what kind of cyst it is, sometimes you can't hit them. A dermoid, you can't touch. Endometrioma, you definitely can't puncture because there's a huge infection risk. So sometimes you can't do it. And because of that, you got to be really cautious. So generally speaking, we don't start a cycle if we see a big cyst in there.
Great drawing.
Is that what somebody said?
They should.
The angry lollipop.
My embryo grade was 5 AB.
Okay.
After thaw, changed to 5 CC. Why change?
Some embryos don't like the freeze and the thaw. It could be a problem with the way in which they froze it. It could be the embryologist. I mean, some embryologists will not agree with the opinion of other embryologists. So my lab director now most certainly does not agree with the quality or the rating of what my previous embryologist believed, because she believes he was overvaluing the the integrity of the embryo. So yeah, I mean, in many instances, we're super careful to make sure that we are grading appropriately. But you put 10 embryologists in a room and put the exact same picture up there, there is virtually no agreement on the quality of the embryos. So it's hard to get the reliability between embryologists. So those are possibilities. So either the thawing process, the freezing process, the grading of the embryo, or it could just be the embryo. I mean, some embryos may look good initially, but after they've had more time to develop, after a thaw, they're not doing as well. And that's a possibility as well.
I have polycystic ovaries,
Okay,
but none of the common PCOS symptoms.
sure.
Enough to rule it out. Yeah, that's it.
Well, lots of people, well, let me back this up. I personally, unlike most doctors out there, do not believe that PCO is a yes or no diagnosis. So for decades, people have been trying to establish criteria to say, if you have this, you have PCO, and if you don't have this, you don't have PCO. It doesn't really work that way. Clinically speaking, it's like a spectrum disorder where you can have really mild PCO, where you just have tons and tons of eggs on the one side. And on the other side, you have the severe PCOs where they're balding and they have acne and they have hair growth and they have oily skin and central adiposity. And, they've got a full-on beard and things like that. So, and then there's everything in between. So I don't believe that PCO is like, you must have these criteria. It just doesn't work that way. The spectrum on that side? Oh, yeah. Male pattern balding, central adiposity or male pattern fat, oily skin, acne, hirsutism. Frequently they develop cancer, high blood pressure, metabolic syndrome, diabetes. It's bad. Luckily, the very, very severe ones are kind of more rare, but it happens.
I have PCOS and would like to try again for a second baby. Breastfeeding 9-month advice.
Stop breastfeeding and then go on the supplements that we always talk about. Use letrozole. I don't know the rest of your history, but that would probably be an easy way to get started.
Are you more likely to have a MC if you've had a previous chemical pregnancy?
So the question is, are you more likely to have a miscarriage if you've had a previous chemical pregnancy? Not one, but if you've had multiple, yes. Those are our advanced questions. That was a lot of advanced questions. Thank you all for sending in your questions in advance. I had no preparation on any of those. So there you go. This is a good thing for me. I got to
this is your test.
This is my test. I know.
So far, you're doing pretty good.
Every time I come in, it's like, oh my God, multiple choice. No.
In front of a camera.
In front of the camera. That's right. Yeah.
Pretty good.
Yeah. Yeah.
I'm going to go with this question here.
Okay.
Because I know you're going to love it. Hi, Dr. V.
I just get scared when you say that.
No.
All right, fire away.
This deserves to be said out loud.
All right.
Hi, V and Dr. T. At this point, people are just messing with us. But I don't mind it. I'm all in.
All right. Yeah.
Can you share again why you don't like the Receptiva DX test?
Receptiva DX is a test designed to find a protein called BCL6 in your uterus. So they claim, based on one not very well done study, that it works and that it can detect endometriosis. The reality is it doesn't work and you can't detect endometriosis with it. So I'm not a believer in it because it's useless. If you want to know if you have endo, you need to go to the OR and see if you have endo. Even at its best, the sensitivity of that test was very, very weak in the studies that they have on their website. And I looked it up. So I'm not a believer. It just doesn't have enough data to support it yet.
Hi, both.
Hi, both.
They're politically correct.
At least they didn't give us Dr. T.
I was thinking of not even asking it because I wasn't properly introduced. And it became part of the equation. Hi, both.
All right. Yeah, you might get an honorary medical degree by the time we...
10
10 years,
of people get them.
10 years from now, when we're done with this show, you never know. Yeah.
So.
Yeah, or probably 20 because we got to keep working until my daughter takes over. All right, go ahead.
My luggage. Hi, both. What form of progesterone is best for recurrent losses?
You want to answer? What's your answer? No, go for it. What's your answer?
Oils are great, and the other ones are great. They're both.
Both, or like one?
You have to have both.
You got to have both? That's right. Tarek's right. So you got to have both progesterone and oil, and you need to have vaginal progesterone. Within the vaginal progesterones, there probably isn't a huge difference, although I won't lie, I do love crinone. But they're all pretty much the same. So you need the progesterone and oil for sure. If you can only use one, you want the oil, but you should use both because both is better than one.
See that, Dr. T's getting kind of close.
Good job, man. I'm proud of you. Well done.
Great teacher.
A great teacher. There you
Great
go.
teacher. What is best, a HCG of neupogen wash?
Well, they asked that one before.
Oh, okay.
Yeah.
They're
They're the same. HCG and neupogen have roughly the same increase in success. So I would actually advise you do both. But there's a lot of things. We just made a video yesterday about the top 5 adjuncts, and we're going to make a separate video on neupogen. So it's coming, I promise, but I need some time to put it together.
Hello, I'm from Detroit, Michigan.
Yes, I love Michigan because my cottage is in Michigan.
Detroit.
Well, my cottage is in Detroit, but I did my training in Detroit. Go for it.
I did an IUI in April for the first time.
Okay.
It came back negative.
I'm sorry.
I have no health issues.
Okay.
I went Saturday. I had already ovulated, so now on timed intercourse help. Yeah, that's it. That's the question.
Help? I need to know so much more about you. So, how old are you? What's your body mass index? What's his sperm like? Does he smoke? Does he drink? Does he do drugs? Do you do any of those things? What's your obstetrical history like? What's your gynecologic history like? Body mass indexes for both. All sorts of things. Your hormone levels. What's your thyroid doing? I can't help without knowing more. So those are the kinds of cases where we need to understand more about you, and then I can tell you exactly what you need to do. Sometimes you don't even need the IUI. A lot of times we fix things without having to intervene at all. Sometimes you need more than the IUI, and lots of times the IUI is the trick that makes it work. So you're certainly welcome to reach out. We take care of patients from Detroit all the time. I love our Detroiters, but either another doctor near you or us would be happy to help you out and figure out what you need to do to get pregnant quickly and efficiently and without an enormous amount of cost. I'm super curious to know, and if you're still watching, I would love to know how much it costs to do an IUI in Detroit. We charge $350 Canadian here. So tell me what it costs out there.
Question I went. Let's see what she says.
All right.
What dose do you use neupogen for after 2 failed transfers? How can it help? Is it a one-time injection or daily? My work plan doesn't cover it, so I want to know what to expect. So
we haven't started using neupogen as a wash in the uterus. We use neupogen in your blastocyst transfer media because the studies show that that's where it makes the biggest difference. So rather than injecting it into the uterus, we actually put it in the media your embryo is thawing in. So that has been shown to make a very big difference. So I have no idea what that dosage is because that happens in the lab. And I am hopefully reasonable at doing what I do, which is all the clinical stuff, but I wouldn't even think of touching anything in the lab because that is Dr. Khosravi's domain, and she's awesome, and I leave her alone to do her thing on her own. So she knows that we use it, and she knows when to use it, but I wouldn't have the foggiest what the concentration is. In terms of washes into the uterus, we're just starting to explore that. I'm not sure that there is any evidence to compare whether it's better into the uterus or into the culture, but there is good evidence in the culture media that it actually makes a really big difference in outcomes. So when we've had previous failures, we automatically add it, and we actually do it for free because patients deserve the best, and we believe in giving you the best. And it should be individualized care, not the same thing over and over and over again, which is what we hear all the time. I'm not still sharing, by the way, am I?
No. Your beautiful artwork.
You clicked it off. Yeah. I kind of miss the angry lollipop.
I'll show it again if you want to do it again. Prepping for an FET. If my lining is already 10.5, millimeters at CD8, is it going to continue to thicken leading up to transfer, or is there a way to keep it at that thickness? Yeah,
stop taking too much estrogen, right? So if you keep taking estrogen, it'll keep getting thicker and then it'll over thicken. So we normally will back off if we see your lining at 10. Like I had one today that was at 10. She was on 1 milligram twice a day. So I said, go down to 1 milligram once a day because we need a day or two more before we start her proj.
Hello.
Hello.
Would you recommend PGTA IVF testing for a 30-year-old with 4 unexplained miscarriages naturally conceived? All other tests came back normal.
Yes. Depending on the rest of the investigations I had done for you, so infection testing, genetic testing of you and your partner, sperm DNA fragmentation testing, knowing your history, smoking, drinking, drug use, 3D saline infusion sonohystogram of your uterus, and the thrombophilia screen. Whew, if I had done all of those things and tested your hormones, including a detailed thyroid analysis, vitamin D analysis, iron analysis, and all of that came back negative, as you're saying, then yes, I would advise PGT for sure. And I don't know if I mentioned immune testing, but you need that too. So infectious and immune testing. So if every single test came back negative, yes, I would advocate for PGTA, because the only thing that's left is that the embryos, for whatever reason, are not normal.
Does your office offer gender selection when testing for IVF?
It's illegal in Canada, so I absolutely 1 billion% do not offer gender selection. No one in Canada will do gender selection unless you have a sex-linked genetic disease that mandates that you select one sex because the other sex is going to have a genetically linked condition. So otherwise, no, I have not and never will do gender selection. It is 100% a federal offense. I am not going to Kingston Penitentiary for anyone, not even you guys whom I love.
During the 2-week wait, is intermittent cramping normal?
Excuse me. Yeah, it can be. I mean, it depends on where you're coming from. Fresh cycle, yeah, for sure, because all those cysts are doing weird things inside you. Frozen embryo transfer, you shouldn't really be crampy, but it can happen.
Got the answer from Michigan back.
We got the answer from Michigan back. Okay.
Detroit is on the line.
Detroit, yep.
44-year-old sperm count. 44-year-old, his sperm count was good, 26 million. He had I don't smoke. $576 is the cost. I go to Dr. Carolyn Warren, Michigan fertility doctor. Been on Clomid twice. Follicates, been good, over 18.
So if you're 44, that's IUI is a waste of your time. It'll almost never work. You've got about a 2%, 3% chance, even if everything else is perfect. So $576 US for a 2 to 3% chance, in my mind, is a waste of money. So I would not do that. But that's up to you. I mean, we would support you if you wanted to, but we would not advocate for it. It's not going to work. As far as other things, I still need all the other details on you. But yeah, I mean, it's not, and you've got all sorts of options. It's just a matter of what you want to do. You could do insemination, you could do IVF, you could do insemination with injectable medications. You could do donor egg IVF, which is definitely going to give you your best chance. So there's lots of choices and options, but natural conception or insemination at age 44, if you're referring to your age as being 44, that's very, very difficult to achieve success. It's not impossible. There is a chance, but it's tough. You're talking about very low percentages. Sorry.
Hi, Dr. V. In July last year, my anticardiolipin,
Yeah.
AB,
Yep.
IgM level was 31.
Okay.
In October 26. And in May this year, it was 16.2.
Okay.
Is it possible for it to drop to the normal range if given more time?
So the IgM is the acute phase reactant. So if you're in more of a flare, it'll go up. And when you're not flaring, it'll go down. So yes, that's very possible. That was easy.
Yeah, it was harder to read. What are the chances of having a successful pregnancy with a heart-shaped uterus? I'm currently on the wait list to get a procedure to fix it, and I'm struggling with the long wait. Sounds like a drawing.
So if you have a septum resection, that's a good point. You know what? That is a good drawing. Let's draw.
Let's go.
I need to get a thinner pen. My pen's too thick.
I want to buy you a pencil.
No, it's good. No, I meant I need to pick a thinner line. Okay, so if this, oops, if this is your uterus and that's the inside, you have a septate uterus. So this one is easy because all you got to do is take scissors and cut this out. And then when you're done, it actually looks like that. So I can erase actually, can't I? Yes. So you can get rid of all this stuff. And now you have a nice normal uterus going across the top like that. Okay. If it's indented inside and outside, then you got a whole other issue. So now, if you've got this guy, whoops, let me go back. If you've got this guy, and inside it's like that, you've got a bicornuate uterus. So this is not septate, this is bicornuate. This part, which is the outside, is indented, and the inside is also indented. You can't fix this. I mean, they used to, but no one does it anymore because it's a disaster. So for this, you got to leave it alone. So with the original one, the septate uterus, that's going to give you an 80% increased risk of miscarriage. So it's a very high chance of miscarriage. Does that mean you can't get pregnant? No, you can go ahead and try and get pregnant, but you got to be prepared for the fact that you may have miscarriages.
That drawing was very insightful.
Was that insightful? Excellent. All right.
Thank you so much. Should you stop taking CoQ10 if you conceive?
No, it's harmless. It's already in every one of your body cells. There's no detriment to going and staying on it.
Can I continue with a preparation for endotransfer if I'm positive for COVID?
Can you? Yes. What does the research show? It shows that there's probably no difference. Would I do it? No, because it doesn't make biological sense that after you're super inflamed, which we all know happens from a COVID infection, that it's not going to have an impact on your ability to achieve a pregnancy. Now, if you're happy with average success rates, fire ahead. If you want exceptional success rates, I wouldn't do it.
Is it normal for PCOS patients to have elevated prolactin levels? Mine are usually 40 to 55 nanograms per liter.
No. PCOS and prolactin have nothing to do with one another. So if you have monomeric prolactin elevated, you need treatment for that.
What's the benefit of using Moniker instead of gono, F, and lupon? My stem cycle didn't use Moniker. I have PCOS.
So Menopause has HCG in it, which has LH activity. And women with any kind of diagnosis, their eggs will respond better if you give them some LH and some FSH. Now, granted, PCOS women have a lot of LH. Nevertheless, you want to give them both in order to maximize the quality of the eggs that you are getting. And that actually was shown in the original Menopause trial, where embryo quality was slightly better with Menopause than with gonal F. And that was taking everybody into consideration.
Weird question.
Weird question. Okay.
Do fertility doctors hang out together?
Wow. Yeah. I mean, I go out to dinner once in a while with Dr. Pattinson, who's my nearest colleague. I've been out to dinner with Fred Zaneku. I don't hang out with other fertility doctors, but we do when we go to conferences. So I'll meet a lot of my colleagues and friends from the States, some from Canada when I go to Chicago tomorrow. So yeah, we go to dinner together. We talk. And Tarek feels that he's a fertility doctor too. So Tarek and I hang out all the time. We're going to create him a fake diploma of medicine from the Fertility Fact or Fiction School of Medicine. We should get that. We should make you a little diploma. Yeah. The FFOF diploma, medical school diploma.
Yeah.
So yeah, we hang out, but not like a lot. And certainly very rarely if you're talking about doctors from different clinics. There's just too much competition and people don't like sharing, and inevitably it becomes shop talk. So, I've had lunches, I've had dinners. If we're at a conference, we all collegially hang out. And I've had lovely meetings with people from all over the world, but we don't like socialize. Having said that, my colleague here, Dr. Pattinson, whom I love dearly, we work together very well. And Carrie Mayrand, who is a family doc that works with us and getting her fertility designation, I love Carrie to death. We do stuff together all the time. So yeah, I mean, sometimes we do, but not with other centers usually. Interesting question. No one's ever asked us anything like that.
You like it.
That was cool. I like that one. Thumbs up for the person that asked that question.
Yep.
I wonder if we did a video or a show on people just asking us questions about us, if people would watch. We should. I'm curious to know. Do you guys want to know more about us? Me, Tarek, our families, that kind of thing. If you do, by all means, we'll do a show on that. I think it'd probably be pretty boring. I'm an open book anyways. But if you want to know, sure, we can always do that too.
Not today.
Not today.
Not today.
No.
Hi, guys.
Hello.
Is Orilissa used to treat endo? Can it be used instead of lupon in combination with letrozole?
Yes, but we don't know that it works as well. And you don't get the same level of estrogen suppression with Orilissa that you do with lupron. So if you're talking about using it for endo, it won't work as well.
Here's a couple question.
A couple question? Oh, wow. You've never said that before.
Yes.
All right.
New line.
All right. Couple question.
Hi, Dr. V.
Okay.
If I only have
That's
one
a good
PGA
start.
tested normal.
Yeah.
Day 6.
Okay.
5 AA.
Oh, nice embryo.
For transfer and
Yeah.
turning 40.
Okay.
And don't plan to do any IVF. What tests do you recommend to do? My doctor said only sonogram and thyroid. As I am afraid of success rates of the first transfer at my age might not be great. By the way, had DNC before.
So I would advise you do everything. So we would do the Fertility testing for your immune system and for infection. You definitely need your iron and vitamin D checked. You need a full thyroid panel. Check your cholesterol, check your sugar, check your insulin. Make sure your body mass index is appropriate. You do need to do a 3D saline infusion sonohystogram. That should have been done before you ever did your IVF. All of those things are important.
Hi, Dr. V. For FET, my doctor recommended tacrolimus for my next FET.
Sure.
It's safe.
Yeah. We've presented it on the show. It's very safe to use tacrolimus and sirolimus. So one study we presented 6 months ago, which was a review of all the immune stuff that can be used, said that sirolimus was actually the #1 most beneficial immune product to use to help people try and conceive. So sirolimus and tacrolimus are basically the same thing. So yes, you can use tacrolimus and it's safe.
Can you only get an isthmusal from previous C-sections? And would a tummy scar have any effect on this?
A tummy scar? Like a tummy tuck? No. So yes, you can only get an isthmusal from having surgery on your uterus, which is either a myomectomy that went all the way through or a cesarean section. And a tummy scar that does not go into your uterus has no impact on anything.
What does it mean when your follicles don't grow during your cycle? What can be done?
Oh, well, either you didn't get enough stimulation or you didn't get the right meds, or you were suppressed or stressed, which causes suppression. The meds were bad, or the eggs are bad. So those are all possibilities.
Hi, Doc.
Hello.
Not sure if it was for me or you.
Just putting it out there.
May I ask, what supplements can you recommend for PCOS?
We answered that, but I'll do it again. NAC, inositol, coenzyme Q10, and resveratrol are the 4 that are good for PCOS.
A question. That looks good.
Okay.
Hi, T. And Dr. V.
All right.
When would be an indication for a hysteroscopy? 33 years old, PCOS with failed 2 transfers.
If you've had a 3D saline infusion sonohystogram, to be honest, there really isn't a great indication for hysteroscopy unless they weren't sure about something that they saw or they're worried about something that they saw or something like that. You'll get more bang for your buck out of things like fertility, immune testing, thrombophilia screen, sperm DNA fragmentation for your partner, genetic testing, all of that other stuff. So I mean, like I love doing surgery and I'm an expert laparoscopist, hysteroscopist. So there's nothing I can't do with a hysteroscope, but I wouldn't offer people hysteroscopy if I'd already done a saline infusion sonohystogram. So I'm not sure in your particular situation, it's useful. If you haven't done a 3D saline infusion sonohystogram, first of all, I question the center you're working with because that doesn't make sense. And then second of all, yes, in that situation, it's totally appropriate to do hysteroscopy to see what the shape of your uterus looks like, what does the cavity look like, what's the quality of the endometrium, are there polyps, are there fibroids, all of that stuff.
I just had a failed transfer last week with donor.
I like the drama. Tarek's actually going like this as he says, I just had a failed transfer.
Yeah,
okay,
I
yeah.
feel it's
You're feeling it.
yeah.
I love you, man. You're the best. All right.
With donor eggs.
Oh,
Yeah,
that's rough.
yeah.
I feel that too. Okay.
At the age of 42 with a lining measuring 11 and 7 on each side. What can be the issue? I have fibroids outside the uterus and no scarring in the uterus.
If it was a donor embryo, or I mean a donor egg embryo, could still be your partner's sperm. Could be the quality of the embryo still. There are going to be genetically abnormal donor embryos, so that's a possibility. Quality of your lining. Did they give you tons of estrogen, especially with large fibroids there? Because that's a bad protocol. You should be on a letrozole protocol. Infections in your uterus, your immune system, your weight, your habits, your partner's habits, like all of this stuff plays a role. So reach out to me and I'll be happy to go through it with you and we can figure it out together. Those are the cases where I tend to kind of really excel and shine because I love doing the sleuthing to figure out what's wrong. Oh, and endometriosis. Tarek and I had a whole discussion at dinner about endo. So yeah, it could be endo. Like there's all sorts of possibilities.
Why is lupon used in an FET protocol? I start next week.
So in an FET protocol, the key is to get the lining to thicken enough to accept an embryo and then start your progesterone. If you don't suppress your body's natural response to things, as soon as the lining gets thick enough, you will release an egg because the lining gets thick because of estrogen. And when the estrogen hits the right peak, you end up releasing the egg. The minute you've released the egg, you start making progesterone. And then we can't get the timing right if your lining didn't thicken up quite as much as we want to. So the reason we use lupron is lupron prevents you from releasing the egg. So this way, if I need to go 10 days, 11 days, 14 days with the estrogen or the letrozole or waiting for your lining to get to the thickness I want it to, I can do that.
Can your body reject donor embryos? I had a big E antigen, but testing was done to make sure the male, make sure they mate, maybe.
They match?
They match, maybe.
You wouldn't have to worry about antibody sensitivity for an embryo because your embryos aren't producing those red blood cells until weeks later, like not usually until 6 or 7 weeks. So that's not going to prevent you from getting pregnant. I mean, same thing I answered earlier, right? There are lots of reasons why embryos don't implant, whether they're donor or not donor. So your health status, your partner's sperm quality, his health status, smoking, drinking, drug use, body mass index, endometriosis, infections in your uterus, your immune system, your blood delivery, your blood thickness, vitamin levels, supplements that you're using, the protocol that they used for you. There are loads of things that can go into it. How did the transfer go? I mean, it's not all you guys, right? So we always talk about the destination, the passenger, and the passage. So the destination is you. So all the things I just discussed. The passenger, was it a good embryo, right? Could it be a bad embryo? And then the passage, which is us. Did we put it in the right place? Did we do it quickly? Was it efficient? Was there tons of blood pouring out of your cervix after because we didn't clean you properly? Did we get mucus in there, which is a disaster? Was it difficult to see and we weren't sure where the hell the thing went? So all of these things are really critical to figure out.
So
it's not just a throw it in there. No, definitely no.
Have previously had previously had chemical pregnancy early losses.
Okay.
Currently 5 weeks. This is the furthest I've got.
Oh, cool.
I be worried about another loss?
Worried, no, because that's just going to stress you into problems. But judiciously happy, yes. So just be cautious. Always want to make sure you don't get emotionally invested to the point where it's devastating for you. But at the same time, there's always hope. So be hopeful.
I take 25 milligrams per day of cortisone.
Cortisone?
Cortisone's name's Gupazone.
Never heard of
Pregnant with IVF.
Gupazone.
AM 9 weeks. Does it have side effects on my body?
Cortisone has side effects, weight gain, high blood pressure. Some people go crazy from it. You can get thin skin, bruising, striae, which are streaks on your skin. So yeah, there can be, but you're not on a very high dose. So I doubt it'll be significant.
Hi, Dr. V.
Hello.
How do you treat an inflammation in the uterus that is causing free fluid? Is surftraxone injection an effective treatment for this?
Ceftriaxone? See?
Ceftriaxone. Yep.
No. Okay. So actually, it's interesting that somebody asked me this because one of my medical colleagues asked me this today. Maybe you are that individual's patient. I don't know. When you have fluid in your uterus, the most common reason is that it's either coming from fallopian tubes that are damaged and blocked, or it is coming from a C-section scar called an isthmusele. So let's draw.
Oh,
yeah.
This is a fun day.
It is kind of a fun day. So if it's coming from your fallopian tube, because your fallopian tube is chock full of water, then the fluid is going to leak into the inside of your uterus because there is an open channel through here, and that's how the embryo gets in. So you'll get fluid. So some people bring a clip and they clip across here, but that's not going to really work. You need to remove those tubes because they're just causing inflammation, and inflammation isn't good. So we actually recommend that you remove the tube completely, and that's been shown to be associated with a 50% increase in success. If you have an isthmusele, so that's when your uterus is like this, and on the inside you've got that shark fin, because this is where your C-section scar is. I kind of goofed up that last part, didn't I? So if you have this isthmusele, which is that part right there, so then what you need to do is you need to go in with a camera and you need to burn all of this and all of that, and then it'll kind of seal together and it'll stop producing fluid. If you have neither of those things, then you need to check for infection inside the uterus, and we use Fertility to do that. Very, very, very difficult to get a uterus to stop producing fluid in it if you don't have an isthmusele and you don't have hydrosalpinx. You can try sucking it out by putting in a catheter there and hoping that the fluid will get sucked up, but it doesn't work well at all because there's so much inflammation that's causing that fluid. Your uterus is not a friendly place.
This is a nice one.
A nice one. We like nice ones.
Yeah. Hi, doctor.
Hello.
Why don't you share with us some experiences that were impossible to conceive, and for somehow the result in life birth, even with difficulties, just to give hope for people who suffer a lot?
I had a patient who's currently pregnant. I just saw her today. She's a lovely young lady. She's young. Her ovaries were completely failed. She was menopausal. She insisted that we try. I told her there was very, very low chance, but that I would help her. We made her make just one egg. We made the one egg. We made it into an embryo. We told her to come back for a fresh embryo transfer. We did the embryo transfer. She got pregnant. We checked to make sure it was normal. It's normal. She's currently making it through her pregnancy. So, you know, even if you can just make me one egg, because I do need one, I can get you pregnant. Not everybody, not every time, but there's always a chance, and there's lots of hope for everyone. So I got lots of stories like that. I've got bucket loads of people with severe endometriosis where all we did was operate and they got pregnant, because I believe in operating on people with endo. We've got people with severe recurrent pregnancy loss or recurrent implantation failure. They see us, we figure out what's wrong, we fix it, they get pregnant. I've got patients that have early second trimester losses. That's the worst thing you can have, 20 weeks, 22 weeks, 23 weeks. I have done everything humanly possible to keep them pregnant, from literally hanging them upside down for months. Yes, I have done that to many people, to antibiotics on and off and cervical cerclages, and we keep them pregnant too. So Tarek and I are reworking the website, and we were writing a line last night about, you know, how we're different. And, you know, the thing that I wrote about was the fact that we don't do cookie cutter medicine here. I always individualize the care for you, because cookie cutter medicine is just the wrong thing to do in infertility. It's great for making money. Like, let's be honest, right? If you want to turn a printing press of money, yes, you can do that by doing cookie cutter medicine. Why? Because your success rates are low. Patients have to keep coming back to do more and more IVF. You make extra money each time. But I like to actually sleep with a morally clear conscience. So for me, if I have not done my absolute best for you on first try, I have failed you. And so we make sure that we are giving you customized, individualized protocols that account for you. So the supplements are for your diagnosis. The vitamins are for your diagnosis. The dosages, the protocols, which meds we use, what stimulation protocol, how long we go, how short we go. Like, everything we do is all about you. And we change it based on parameters. Now, sure, lots of people fit into one, you know, picture, and we use that protocol for them. But a lot of people don't, and we don't do the same thing for all of those. So it's really, really important to get individualized care. This is something that actually I learned from my amazing, wonderful, and incredibly smart cousin, who's a cancer specialist in Atlanta in the US. And he brought me on to the idea that cancer treatment has become extremely personalized, right down to figuring out what genes you have in your tumors to figure out what to target. And I said, why aren't we doing this in infertility? And that's when it struck me, we got to do this in infertility. So that's when we started to really individualize years ago. And, you know, God bless you, Aaron. I love you. My son's named after you. Like, that's what works, right? So when you individualize for people, you get great results. If you just do the same thing for everybody across the board, you suck. Like, I don't know how else to put that, right? I think that's perfect. But you're just not good. And so, you know, we put it on our new website. That Freud said it. The definition of insanity is doing the same thing over and over again and expecting a different outcome. I'm not going to do that to anybody. I won't do that to anybody. That was 8:59. Like, we should just end it there.
Well, it's ended on a high note for sure. I'm okay.
Is that good? Are there a ton more?
Yeah, you're not going to get through this.
Any amazing ones that we can answer? Anything you guys want me to ask or find out about when I'm in Chicago from other world experts that are there, I will be happy to take our questions. You know what? That'd be a good thing to do. I'll run around and say, hey, here's a question from one of our viewers. What are your thoughts on this? And ask some other doctors. We never thought of that. Send us some questions. I can ask some other experts and see what their opinion is.
People would definitely watch if we talked about ourselves.
Oh, people would watch if we talked about ourselves.
That's the rumor. There's a bunch of yep, yes, absolutely.
You know what? We'll do a show where they can ask me about me, and they can ask you off camera about you.
The mystery of cover.
I'm gonna make you sit here with like one of those ski
mask, eh?
the balaclava.
Don't be too afraid.
Yeah, that's actually not a good look for a
Ski
Middle
mask is
Eastern
not good on
Middle
it.
Eastern dude with the
It can
balaclava.
only go downhill with the ski mask on.
All right, yeah. Next,
Yeah, you got a lot.
we got a lot.
Yeah.
Oh, I got to get home and pack too because
Yeah.
I got to go tomorrow. Pick one good one.
You know, I was looking for one that said "Hey T," but no one did. So
Yeah.
I'm kind of thinking.
Okay, word to the wise. If you don't say "Hey T" first, he's not picking you anymore. You got to butter up Tarek here before he'll answer.
We'll go with. I'm just gonna take a shot on just anything.
Okay.
There really is a lot.
Okay.
I have low AMH.
Okay.
0.3.
Oh,
Is
okay.
it possible to see more follicles develop after baseline with the right protocol, like starting with lupon, or is it unlikely due to the AMH?
It's possible, but the question is, are you going to make 5? Probably not. Will you make 1 or 2? Maybe 3, possibly, and your protocol will make a difference. You should be using letrozole because that's categorically proven now to be beneficial. You may want to use steroids like dexamethasone. You should probably be using a lupon flare and then see how you do.
I know too.
Okay, guys, it's time to call it quits because I got to go home and pack. So much love to all of you. Thank you for switching nights with us tonight. Next week on Monday night is my son's graduation. And on Tuesday night, we have journal club. So I'm not sure what we're doing, but we will let you know. And we will be back in touch with you soon. I hope you guys have a great week. For those of you that are still trying, our hearts go out to you. We are here. Our whole team is here to help you out. Reach out, get a consult. We have helped literally thousands of people get pregnant when they couldn't before. And we don't even make you necessarily come to us to do it. I love helping people wherever they are. So reach out and see if we can help you. Stay in touch and stay safe. Have a good night. Bye.